Hello, hello. Thank you all so much for joining us this afternoon. Our topic today for our August webinar is Strengthening Resilience, Identifying and Reducing Suicide Risk Among Our Older Adults. My name is Emily. I'm the Communications Coordinator here at OSPF, and I will be your host for today. But before I hand it over to our two fabulous experts, I have a couple of housekeeping items I wanted to go over. So after today's webinar, you will all receive a follow-up email in your inbox that will lead to the post. They'll have a link to the post-webinar survey. If you are interested in receiving CEU credits or a certificate of attendance, you must fill out that survey. I do want to preface that only OSPF members can get the CEU credits, but anybody can get the certificate of attendance. And please make sure to fill that survey out within a week, so that puts us at August 26th. I will also in that email include a link to the presentation, which will be published to YouTube, as well as Megan and Tania's slides so that you can review them at your own leisure later. And then at the end of our presentation today, we're going to have time for Q&A. So if you have questions throughout the presentations, please use the Q&A feature down at the bottom. And I will make sure I keep track of those, and I'll share them in the order they're submitted with our speakers when we get to that portion. We do have a lot to cover today. Both Tania and Megan are presenting. So if we are running low on time for Q&A, feel free to send your questions over to them directly afterwards. Their emails will be in that recap email. All right, I think that's all I've got. So without further ado, let me introduce our two speakers. Starting with Tania Matthews, she is a senior program coordinator with the Division of Community Training and Staff Development at Montgomery County Alcohol, Drug Addiction, and Mental Health Services. In this role, she leads and coordinates the Montgomery County Loss Team, ensuring timely, compassionate, and structured support for individuals and families impacted by suicide loss. She oversees team development, volunteer coordination, community partnership, and postvention response efforts to strengthen the county's crisis response system. With 20 years of experience in human services, Tania brings expertise in program coordination, behavioral health, and community engagement. She's a licensed social worker and holds a master's of science in social administration from Case Western Reserve University. And we also have Megan Johnson. Megan is the compliance director and a licensed social worker at Area Agency on Aging, PSA2 in Dayton, Ohio. She has been a passionate advocate for older adults in a variety of roles at AAA in the last 15 years. She has a Bachelor of Social Work from Wright State, and she is currently working on her master's in the study of law at OSU. In her free time, she loves mentoring the next generation of strong women as a Browning Girl Scout troop leader. Ladies, I can't thank you enough for being here today. Tania, I will have you kick us off, and then at about 12:40, Megan will take over to wrap us up.
Thank you so much. Let me share my screen. If I get a thumbs up, I'll
Yep,
go ahead
slides
and
look
get.
good.
All right, perfect. So, as I was introduced by Emily, I'm Tania Matthews. My work with both training and the loss team has given me an opportunity to look at suicide prevention from a couple of different perspectives. First, through a prevention lens of what we can do before a crisis occurs. Next is what we can learn when we look at circumstances surrounding suicide deaths through things like our Suicide Fatality Review Committee. And then finally, how we can prevent further deaths with postvention through things like our loss team. Today, we're going to focus specifically on older adults and what suicide prevention can look like across healthcare, behavioral health, within our families, and our communities. By the end of our time together, I want you to be able to do two things. First, I want you to be able to identify some risk factors and warning signs associated with suicide among older adults. And second, describe opportunities for strengthening suicide prevention through social connection, our behavioral health, and healthcare systems. Lethal means safety through things like training with CALM, which is Council on Access to Lethal Means, and community support. My hope is that you leave with at least one thing you can take back to your own organizations, your community, and your personal settings. So first, when we hear the words suicide prevention, many of us immediately think about identifying someone who is suicidal and connecting them to treatment. And partially that's because most of us have taken trainings like QPR, Safe Talk, and Assist, and that absolutely matters. Clinical intervention is a very important part of suicide prevention. But suicide is more than an individual crisis. It is also a public health concern. Suicide affects individuals, but it also affects the people and systems around them. At the individual level, we may be looking at things such as mental or physical health, pain, trauma, and hopelessness. At the family and relationship level, suicide can intersect with grief, loss, caregiving, isolation, and disruptions in relationships. And then finally, at a community level, well, not finally, we have communities and systems. Community, we have to think about social connections, access to care and resources, and the impact of stigma. And then in the system level, where many of us are today, we look at places and services that are interacted, that people interact every day, such as our healthcare, behavioral health systems, aging services, emergency responses, and prevention systems. So, a public health approach doesn't replace clinical intervention, it expands the conversation beyond the individual crisis and asks us to look at the broader conditions that can increase risk to individuals or strengthen protective factors. And that's the lens we're going to use today as we specifically focus on older adults. So, if we were to take that broader view, the next question becomes, where do we see the greatest opportunities for prevention? A public health approach asks us to look for patterns, not just an individual experience, but across populations and circumstances. So, first, who may be experiencing disproportionate risks? Are there groups or populations that are experiencing higher rates of suicide or particular vulnerabilities? Second, what factors may increase vulnerability and what factors may provide protection? This could include things like health, relationships, social connections, access to care, or other circumstances in people's lives. Third, where are people spending their time and interacting with others? Where are they living? Where are they working, receiving health care, accessing services, and connecting with their communities? And then finally, where are the opportunities to intervene, right? Prevention can happen before a crisis, during a crisis, and through support after a crisis. Importantly, identifying risk factors does not mean that it causes suicide, right? So risk is not destiny. And the presence of protective factors does not eliminate risk of suicide. What we're going to do is we're looking at patterns and opportunities, places where we may be able to strengthen protection and reduce risk, right? So when we start asking these questions, we also recognize that there isn't one suicide prevention strategy that works exactly the same way for everyone. Different populations may experience suicide risk differently, right? Their circumstances, barriers to care, sources of support, and opportunities for prevention can look very different. For example, the experiences and needs for a veteran may be different from those of LGBTQ plus individuals, a person with disabilities, or even a young person. That means prevention strategies need to take those differences into account. Age is another important lens. Age itself can change the context in which suicide risk develops and how we recognize it. As people move through different stages of life, their health, relationships, roles, independence, and connection in their community change over time. Those changes can influence both vulnerability and protection, and they can also affect how we as community providers recognize suicide risk. In a moment, we're going to look at what the data tells us about older adult suicide deaths, what some of the circumstances surrounding suicide among older adults may look like, and we're going to identify opportunities for prevention. Before we before we narrow our focus to older adults, we're going to take a look at the larger picture. So, from a study from the CDC in 2024, you can find this statistical data on the American Foundation for Suicide Prevention .org suicide stats page. But in the United States in 2024, suicide was the 10th leading cause of death. And as you know, with most research studies, we're going to be behind about 2 years. But it was the 10th leading cause of death. That was equivalent to 48,824 people dying by suicide, right? That would be 133 per day or one person every 11 minutes. In addition to that, 2.2 million people attempted suicide, which was an increase from 2023. Men died by suicide 4 times more often than women, but women attempted suicide approximately 2 times more often than men. So this also pushes the fact that suicide remains a significant public health concern in the United States. These numbers represent individuals, families, communities, all affected by suicide, but the overall number doesn't tell us everything. To understand where prevention opportunities may exist, we also need to look at rates across different populations. So, in this chart, which again was from the CDC, from the National Vital Statistics System of 2024 mortality data from CDC, we're going to look at rates. So, when we think about rates, one thing I want to clarify before we look at this graph is the difference between a number and a rate. A number tells us how many deaths occurred. A rate helps us to understand how frequently something occurs within a population while accounting for the size of that population. Now, I want you to take a look at this chart and see if you can determine which age group had the highest number of suicide deaths. In this particular chart, again, with CDC from the 2024 mortality data, it looks at 10 years, right? So 5 to 14, 15 to 24, and so forth. So take a second and think about who do you believe has, or who have you heard had the highest suicide rates? And now I'm going to show you. So the national average is 14.4 suicide deaths per 100,000. Now, is anybody surprised by what the data is telling us? When we look at suicide rates by age, we see that the oldest age groups experience some of the highest suicide rates. Approximately one adult age 65 plus dies by suicide every 50 minutes, right? That would be equivalent to the time that we spend on this call today in our webinar. That is one reason age is an important lens for suicide prevention. Adults age 85 and older, when we look at this, they have 21.4 deaths for every 100,000 people in that age group. Again, that rate is even higher than the national average when we're not considering age. So what does this mean when we think specifically about older adults, right? Older adulthood brings unique challenges because they can experience circumstances that intersect with suicide risk in ways that we may not always be, that may not always be immediately visible. Changes in health, mobility, independence, relationships, housing, finances, and social roles all can change someone's day-to-day experience. And some of these changes may be viewed as simple parts of getting older, and therefore it may be difficult to connect those changes with suicide risk. That's where prevention becomes especially important. We need to be careful not to normalize significant changes in mood, function, connection, or behavior simply because someone is getting older. Again, aging itself is not the risk factor. Risk can just increase when significant stressors, losses, isolation, health challenges, and access to lethal means converge. We've looked at the national picture. Now let's bring this closer to home and look at what we're seeing in Ohio. And then specifically, I am going to focus on Montgomery County a little later in this presentation. Before we look specifically at Ohio and Montgomery County, I want to take a moment to look at what we know more broadly about suicide among older adults. There are several characteristics that are important for prevention. Older adults, particularly older men, can experience elevated suicide rates. Firearms are also an important lethal means consideration. They are the most common method of suicide among males and particularly prominent among older adults. We also know that suicide attempts among older adults may be more medically serious or lethal. This makes early recognition and lethal means safety especially important. The important point here is that prevention can't begin only when someone tells us that they're suicidal. We need to recognize changes and concerns early and look for opportunities to make environments safer. But national data doesn't necessarily tell us the whole story. So what does it look like closer to home? Let's look at how Ohio and Montgomery County compare. So for comparison, we're defining here older adults as 55 and older. In this particular chart, we use the same age grouping across all the three geographical areas, Ohio, Montgomery County, and National, which is the 15 to 34, 35 to 54, and 55 and older. Okay, and this data came from Ohio Department of Health and also from Ohio Department of Health CDC Wonder. When we look at the data, we see that adults ages 35 to 54 have the highest suicide rate in Ohio at 21.2 deaths per 100,000. Montgomery County shows a somewhat different picture. Among adults ages 55 and older, the suicide rate is only 15.3 deaths per 100,000, compared with approximately 18 deaths per 100,000 nationally. So in Montgomery County, older adults don't have the highest overall suicide rate compared with other age groups we're looking at. And our rate for adults 55 and older is lower than the national rate. But that doesn't mean older adults aren't an important population for prevention. What it does tell us is that we need to be careful about assuming that national patterns automatically tell us where the greatest opportunities for prevention are in our own communities. National data can help us identify broader patterns, but local data help us to understand our community and decide where and how we can act as a community. And even when a population doesn't have the highest overall rate, one suicide death is too many, right? And there may be specific characteristics or circumstances surrounding those deaths that point us toward important prevention opportunities. That's what I want to look at next when we focus specifically on older adults who died by suicide in Montgomery County. Now, this data was pulled from our Montgomery County Coroner's Office. I work very closely with our Coroner's Office as the coordinator of the loss team, as well as our public health, where I'm able to get up-to-date data. So this data is from 2021 to 2025, okay? Among adults 55 and older, again, we're going to focus on older adults, which is defined here as 55 and older. We see patterns in the demographic characteristics. We see patterns in methods and circumstances surrounding these deaths. Older adult suicide deaths were disproportionately male and white compared with younger individuals who died by suicide. Among those aged 55 and older, 86% were male, compared with 76 among those younger than 55. We also see that 93% of the older adults were white compared to 75% of the younger adults. When we look at methods of suicide, we see that firearms was the most common method at 72%. One of the things that really stands out in our local data is the connection between physical health and suicide prevention. Nearly 9 in 10 older adults in this review had a physical illness. Heart disease was the most common. More than half also had a documented mental health disorder, with depression and anxiety among the most common. As a suicide fatality review committee, we quickly started having conversations around if someone is managing chronic illness, pain, decline in function, or a serious diagnosis, or emotional health needs to be a part of the conversation, right? So when we see that these conditions, how can we start to have these conversations? This reminds us that suicide prevention among older adults cannot be separate from healthcare. The question isn't simply, does this person have a mental health diagnosis? The question is also, what is the person experiencing because of their health? Another important finding is the amount of contact many individuals had with the healthcare system. More than 4 out of 5 had experienced a hospital stay during their lifetime, and approximately 1/3 had a healthcare visit within the year before their death by suicide. That also raises another important prevention question. Where are the opportunities to recognize distress? Healthcare settings may be one of those opportunities. If we're already seeing someone because of a serious illness, the chronic conditions, pains, and other health concerns, we have an opportunity to ask about how they're coping, how connected they feel, and whether they're experiencing significant emotional distress. Um, so here in this data point, nearly 3 out of 5 individuals had a recent life stressor. The most common was a severe or limited illness. Again, this is looking at older adults 55 and older. This is important because it reminds us that suicide risk doesn't occur in isolation. Life circumstances can quickly change, particularly when someone is dealing with illness, loss of independence, changes in relationships, or other major transitions. These are opportunities for us to increase connection and support rather than waiting for a person to reach a crisis. The other data point in here that's really important is approximately 1 in 4 had known suicide ideations during their lifetime. That finding is important, but I also want to recognize what it doesn't tell us. A lack of documented suicidal ideation does not necessarily mean that someone was not experiencing distress. Sometimes the warning signs are not verbal. You know, everyone is not going to be verbally state that they're suicidal. They may show up as changes in functioning, withdrawing, hopelessness, changes in health behavior, giving away things, or increased focus on death. Okay. And then here are some of the resources for the stats. This information will be made available to you after the training, but I just want to point out that I do have where all of this data is coming from. So if some of the risk isn't necessarily being expressed as I want to die, what might we actually notice? This is where I think that idea of hidden risk becomes useful. So one way to think about this is the difference between a sign and a symptom, okay? A sign is something we can observe. It's something we might notice has changed in a person. Whereas a symptom is something the person has to express and communicate to us, something we may not know unless we ask. So, for example, we may see changes in someone's health or functioning. We may notice that they're having difficulty doing things they normally do. We may notice a loss or a major transition in life, such as retirement. We may see changes in connection. Maybe they're withdrawn from people or activities that they previously enjoyed. But there may also be things we can't see unless we create the opportunity for the person to tell us, such as hopelessness, feeling like a burden, or thoughts about death or suicide. That's important because not all warning signs are verbal. Someone doesn't have to say I'm suicidal for us to notice that something has changed. The goal isn't to assume that every change means someone is suicidal, but it is important to recognize when something is different. And if it could be connected to suicide, become curious, ask questions, You want to offer support and connect with community resources if at all possible. A change in functioning, withdrawing losses, increase focus on death, or changes in mood may have other explanations. But whenever your thought is, could this be connected to suicide? I want you to not ignore those warning signs. When we notice significant changes, we shouldn't automatically just write them off as normal parts of aging. They give us the opportunity to check in. These findings also help us to think about where prevention opportunities may exist, but they should not be interpreted as characteristics that predict whether an individual will die by suicide. And then again, something like we like to say at Adam is risk is not destiny, but we definitely should be aware of risk, right? What might we notice, right? I want you to think about what we might notice. Warning signs may look different than we expect. The goal here isn't to become experts or predict suicide. It's to become better at our noticing skills, right? Noticing when things change. What's different in the person's baseline? Are we seeing changes in connection with mood, function, or thoughts and behaviors around death, right? So when we talk about changes in connection, that could be isolation. That could be loss of interest, right? So they're moving away from their baseline when it comes to connection to the people and places and things that they love. Um, when we think about other warning signs, changes in mood, such as like irritability, anger, agitation. Next is changing in function. Again, declines in self-care, changes in sleep patterns, and then changes in thoughts or behaviors around death and dying. I think this is probably the warning sign that I hear most, that individuals tend to just associate with the normal part of aging. Putting affairs in order, giving away possession, talking about or developing a plan, seeking access to lethal means, talking about death or wanting to die, right? So these are all things that we may notice that we want to make sure that if we see them, again, be curious to ask questions. So what do we do with all this information? The warning signs, the risks that we are aware of, the populations that may be disproportionately affected by suicide rates. The purpose of looking at these findings isn't simply to describe what's happening, right? The purpose is to identify opportunities to prevent future deaths. We don't have to wait until someone is in a suicide crisis, again, to begin prevention efforts. Our Montgomery County Suicide Fatality Review Committee, which I'm a part of, reviewed 7 cases in 2025 that I want to talk to you about. All of the individuals reviewed in 2024 were older than 55. This was not intended, but rather a result of the responses we got from our requests from interviews. Cases were selected because there was a next of kin interview or there was a psychological autopsy available. So they are not representative of Montgomery County deaths, but we did find some prevention opportunities that we felt noteworthy to share with our Prevention Coalition, our Montgomery County ADAMHS, and across our systems of care. So our case findings, what we found in those 7 individuals, all of them had health issues that contributed to a loss of independence or functioning. Chronic pain, terminal illness, and disability causing job loss were common. There were barriers to care, including a distrust of physicians, difficulty accessing appointments due to wait time or distances, and a reluctance to engage in mental health treatment. All of the 7 individuals reviewed died using a firearm, and 4 had prior weapons charges or known unsafe handling, firearm handling. 5 had experienced the death of a close loved one, including one who was a suicide loss survivor. So these findings point to opportunities across healthcare systems, community and social systems. So what we found is that we could offer support for at-risk populations, that there was some room for prevention in our medical and behavioral systems. And then also, again, there were opportunities for um, public education campaigns, including like risk factors, warning signs, available resources, and anti-stigma campaigns, which currently we're running an anti-stigma campaign in Montgomery County. So again, learning can mean strengthening the conditions that protect individuals against suicide. Uh, there are several places where prevention can happen, and these are some of the things that we noted, right? Healthcare can address emotional distress alongside physical illness, and that could be integrating. And these are actual recommendations that we made to our prevention coalition, to our behavioral health and healthcare systems at the end of our 2025 review process. So, um, again, that could be the healthcare and terminal illnesses. So integrating psychological or behavioral health into care for people with terminal or serious illness, creating opportunities to address emotional distress alongside physical health. Another one was pain management, ensuring individuals with terminal or chronic illness have access to appropriate pain management and support. Another area that we found was veteran and social connection. So, identifying opportunities to connect older veterans experiencing isolation with veteran specific community resources. Um, Caregiver support, identifying and promoting resources, respite care, education, and support for caregivers who were at risk. Um, Purpose and transition. So this one to me particularly stood out because it was an opportunity that it was a new opportunity, right? So connecting adults transition out of the workforce with aging mastery and other programs that promote purpose, social connection, and healthy aging. Um, Lethal means safety, so promoting counseling and education about safe storage of firearms and medications with older adults serving organizations and communities. And then finally, community connections, strengthening partnerships with senior centers, faith communities, aging services, healthcare providers, and other trusted community settings. So none of these interventions has to wait until someone says they're suicidal again. There may be opportunities. So one of the things that we did here in Montgomery County is we partner with our faith communities, and we started doing training such as Soul Shop for Black churches. We took it a step further, and we also worked with Living Works Faith and had um, a training for, again, faith leaders, and got some of our faith leaders connected so that they can become facilitators of those suicide prevention trainings in their churches, so that we would have a level of sustainability in our community. So I want to thank you for listening to my presentation, but before I end, I want you to think about what could prevention look like in your community. I shared with you some of the things that Montgomery County is doing, but I want you to really think about where do older adults already spend their time? Who already has relationships with them? Where are we already having conversations about health, caregiving, finances, faith, housing, or aging? Those are all potential prevention settings. Our senior centers, our faith communities, our libraries, and even community organizations. We don't necessarily have to build something new. Sometimes prevention means strengthening the places and relationships that already exist. Um, when we talk about suicide prevention among older adults, we're not only talking about what happens when someone is in crisis. We're talking about how we respond to illness. How do we respond to pain? How do we respond to loss, isolation, transitions? We're talking about creating connection and purpose. Uh, we are talking about having local providers, having community members, have church members, having everyone recognizing changes early. We're talking about making environments safer. Prevention can happen, right? And all of us have a role in it. Thank you so much for listening to my presentation, and
Thank you,
I will
Tania.
stop sharing.
That was wonderful. I loved the data that you shared, the information that you shared, and then how you pulled it together to see how we can really get boots on the grounds in our own community. And I'm going to take risk is not your destiny. I really enjoyed that. All right. Without further ado, we're going to turn it over to Megan. That was a great segue talking about how can we make an impact in our own community. And Megan has a new resource that is available that she is going to share with us. So Megan, whenever you're ready, feel free to take it away.
Thank you. And thank you, Tania. That was a fantastic presentation. I really enjoyed that. And I did also really take back the risk is not destiny phrase. It really struck me. All right, give me 1 minute here. I'm going to set up these slides. All right, again, my name is Megan Johnson. I am Compliance Director at the Area Agency on Aging in Dayton, Ohio. Our agency provides home and community-based services and case management to older adults in a 3-county region, Montgomery, Clark, and Greene County in the Dayton area. But there are area agencies on aging in every county serving the state that provide similar services as we do. Our learning objective today is learning how to apply the Identifying and Reducing Suicide Risk in Older Ohioans resource guide to strengthen suicide prevention efforts within professional, caregiving, or community settings. I was a participant in the Ohio Suicide Prevention Steering Committee, which was developed in late 2024 to address rising rates of older adult suicide among Ohio counties, with the goal of developing a toolkit to help professionals and community members respond to that risk. So there were a lot of participants in the Prevention Steering Committee, a couple area agencies on aging, the Jerry Williams Memorial Fund, Ohio Suicide Prevention Foundation, Department of Aging, Department of Health, Veterans Affairs, Ohio State University Medical Center, Life Care Alliance, UMADOP of Dayton, several ADAMHS boards from various counties, and the Ohio Department of Behavioral Health all participated in helping develop this toolkit. Ohio Suicide Prevention Foundation hosted listening sessions, 6 listening sessions across Ohio from January 2025 to May of 2025 in targeted regions. So Belmont, Brown, Clark, Franklin, Mahoning, and Ottawa counties. So those were kind of highlighted as high risk counties in the region, and therefore the listening sessions were hosted in those areas. The older adults were asked specific questions to determine their own perceptions and concerns that older adults had regarding suicide. There were 72 Ohioans who participated aged 41 to 98, with the majority of the individuals ranging between 60 and 80. And it was predominantly female participants. The toolkit was developed by the Ohio Suicide Prevention Foundation and rolled out in June of 2026. The intended audience for the toolkit was community members, caregivers, and professionals. The intent was to be able to address warning signs and risk factors, provide guidance on how to provide both immediate and long-term supports, and connect individuals directly with resources. So now I'm going to share the toolkit itself, and we'll briefly go through that resource with you. So this is the toolkit. It's meant to be a resource guide for professionals, caregivers, and communities. We have a table of contents to start with. This page really just describes the intent of the toolkit and the ways that the toolkit can be used. So you can use this toolkit as a training resource, as a reference if you're doing safety planning with an older adult, just as a framework for community discussions, a starting point for protocol review if you're doing an organizational review internal to your organization, and as a companion to screening and follow-up procedures. So 38% of Ohioans age 60 plus live alone. And there's been a 40% increase in suicide rates among Ohioans age 60 plus over the last decade. So older populations are experiencing increased levels of depression, isolation, and suicidality. Isolation specifically reduces opportunities for detection and support, placing many older adults at risk of not seeking help. Listening sessions with the older Ohioans across the state revealed several common themes brought up by the older adults themselves. So, a strong desire to maintain their independence, a reluctance to address suicide directly or head on, grief following the loss of a spouse or close friend, feelings of being a burden and loss of purpose, often because of systemic gaps in support and stigma surrounding mental health care. Tania brought this up in her presentation, but older adults may not say directly that they're feeling depressed or suicidal, which is why it's really important to pay attention to the signs that you might see. This page is addressing both chronic risk factors, so things that you might see long-term or underlying conditions or behavior that might place somebody at risk of suicide. So things like depression or anxiety, living alone, chronic pain, cognitive decline, housing instability, substance use, loss of independence or purpose, or transportation barriers. Then we have acute warning signs. So these are warning signs that can pop up suddenly or be severe. Talking about wanting to die, feeling like a burden, withdrawal from activities, stockpiling medications, giving away possessions, agitation, irritability, refusal to eat, drink, or take medications, or newly expressed fearlessness about death. So timely and targeted interventions can save lives. So this toolkit provides ways that we can immediately help. So if you're noticing signs, immediate interventions that you could offer, obviously using clear, calm, and supportive language, removing access to lethal means where it's legally and ethically appropriate, providing information about the Suicide and Crisis Lifeline for emotional support, make appropriate notifications if you're in a professional role, or in a caregiver role, evaluating whether authorities or additional support systems should be notified. And then safety planning. Do we need to complete a warning sign checklist, evaluate coping strategies, connect to the 988 Suicide and Crisis Lifeline, or make environmental or safety adjustments? It also notes that cognitive impairments can affect one's ability to follow or adhere to a safety plan. Cognitive support adaptations could include things like environmental modifications, checklists, alarms, and AI-powered applications. It's incredibly important for older adults at risk for suicide to have long-term support. So you're going to have immediate intervention strategies, but those should be followed up by long-term approaches to support their ongoing needs and promote quality of life. So that's going to be connection to treatment and support pathways, offering community and opportunities for connection, and firearm safety and legacy planning. Older adults are also not a monolith. Older adults have strengths and opportunities for resilience. Examples of resilience in older adults could be strong family or community relationships, offering protective factors that reduce suicide risk. If they have access to behavioral health care, management of chronic pain and illness, general awareness of the 988 Suicide and Crisis Lifeline, if they have a sense of purpose and meaning, safe and accessible living environments, and stigma surrounding mental health care. It's important to also reduce suicide risk by addressing systemic barriers that might discourage help seeking. So there's descriptions here that outline for you opportunities to address some of those systemic barriers. Normalizing help seeking, practicing cultural humility, providing language accessible materials, attempting to simplify what can be really complicated systems that older adults are interacting with on a daily basis. Medicaid and Medicare are just two examples of complicated systems that they might be interacting with on a daily basis. And prioritize independence. When it's possible, involve the older adult in the decision-making process to preserve their dignity and build trust. Cognitive impairments can make it harder to identify support needs. Ways that you can help is to screen individuals. So monitor their mood or pay attention to their mood and behaviors and rescreen at regular intervals. You might need to adjust your communication. Use direct language and repeat safety planning steps. Monitor warning signs. So be aware of memory loss, changes in cognizance, language struggles, motor impairments, and behavior and mood shifts. And increase your follow-up. Maintain regular appointments, provide interim phone check-ins, and reinforce use of 988 between visits. Caregivers are critical in the network of supporting older adults and reducing suicide risk. Approximately 1 in 3 adults in the US is a caregiver. The physical, emotional, and mental toll of caregiving directly affects the well-being of our older adults and the caregiver themselves. Caregivers need to prioritize self-care, establish boundaries so they can schedule regular breaks and set realistic expectations, join a support group, ask for help, and consult a professional when it's needed. Agencies and providers can strengthen their suicide prevention initiatives by conducting internal assessments of their policies, practices, and culture. So we have provided some questions that can be administered organizationally for an organization to be able to assess whether it is doing good prevention work. Providing some do's and don'ts as it relates to suicide prevention in older Ohioans. So do's, use supportive communication, reduce the immediate risk, strengthen the support system, coordinate care and follow-up, address real-world barriers, and support caregivers. Don'ts is don't make assumptions or minimize concerns. Critical to not avoid conversations about suicide because older adults are less likely to tell you directly that they have suicidal ideation. It's important for us to ask the questions. Do not exclude the older adult from decision making. Don't overlook systemic barriers. Don't neglect follow-up. And don't use complex language. Avoid vague language, and ensure that the language and message that you're trying to convey can be understood by the person receiving it. Information about the Jerry Williams Memorial Fund, who have been funding projects in memory of Sandy Williams' father, Jerry Williams, who died by suicide at age 74. And then we have a whole section on resources with connection to phone numbers and how you might be able to deliver direct assistance to the older adult themselves. Also a QR code to take you to a link with more information than what is directly listed in the guide here. Okay, one more second here. And then I just wanted to provide you with a little bit more information about the area agencies on aging across the state of Ohio. Both our agency and statewide offer information and assistance resources to anyone who has questions about aging or resources for older adults. For statewide resources, you can reach out to the OBLTSS hotline at 844-644-6582, or we can provide regional assistance at our agency for any of those 9-county region at 937-223-HELP. We provide in-home assessments by a nurse or social worker with no charge, and we establish eligibility for our various programming. We have several programs available to meet the needs of older adults in the communities where they live. And we provide a significant amount of caregiver resources. We have workshops, retreats, book clubs that can provide support, as well as our True Alta, which is an online software program to provide resources to older adults, or I'm sorry, to caregivers in the community. And we have reached time.
Thank you, Megan. That was awesome. And I'm so glad that we could walk through the guide and look at all the different resources that are available. OSPF was really proud to partner with so many different organizations on this, and it's such a valuable resource that we are excited to get out into the community. I'll also share a link to the guide in the recap email so that everybody can access it. We had a couple of questions come through in the chat that Tania and I were able to answer, but if anybody else has any questions, please feel free to pop them in now. I guess I'll ask you both before we conclude. Is there anything else that you want to share that you think is really key in supporting the older adult community that we didn't mention, or you really just want to hit home with our audience today?
I would just like to share, if you're interested in prevention opportunities, I will connect with your local prevention coalitions. A lot of that work starts in those coalitions. And so I would just say take an opportunity to see what work is being done with suicide prevention in your communities.
I would just say don't be afraid to ask questions. Don't be afraid to have the conversation. Older adults might not tell you specifically that they're having these feelings, and you're not going to put any thoughts in anybody's head that they did not have before by simply having the conversation. If anyone has uncomfortable feelings about having those conversations, I highly recommend a training called QPR. Question, persuade, and refer. You do not have to be a behavioral health professional to attend those trainings. They are meant for the everyday person who just wants to learn how to talk to somebody about suicide and how to connect them to resources to make that person safe. And so that's probably what I would leave you with. There are lots of organizations around the state of Ohio that do that training for free. There's usually no cost associated with it. And so if this is a topic that maybe you're a little bit uncomfortable with, I would highly recommend that training.
Great. Thank you both. We did get a question through the chat. They were asking if your organizations work with long-term care facilities. Their experience is that older adults can be very lonely and have depression in these long-term care facilities. And it's an avenue where maybe we could do more. And that it's assumed that resources are shared and provided in them, and that's not always the case. So I don't know if either of you have anything you want to share about that.
I can share a little bit. So our agency is incredibly focused on home and community-based services. So we are serving individuals in the community in the homes where they live. And so our kind of like mission and purpose is to support older adults at home so they do not need to receive care in a nursing facility. Um, so that's not to say that we don't interact with older adults in the nursing facility, but it's a pretty limited population or interaction for us. And we do have a program that receives case management from us in residential care facilities, and those are licensed assisted living facilities. And so we do provide resources and support in that setting as well.
I would like to also mention that for Montgomery County and many local alcohol, drug addiction, mental health services board, Adams boards, we provide free training, suicide prevention trainings to our local providers. And so staff often come and take trainings for suicide prevention, and we provide resources at that time. As far as directly to residents, we don't provide that at this time, but we do train many of hospital staffs and facility staffs. If you're interested in learning more about some of those suicide prevention trainings that I listed, Montgomery County, Adamus, and again, along with other Adamus boards, we have a list of our available trainings. I coordinate all of our suicide prevention trainings here for Montgomery County Adamus, so you could always reach out to me. Some of the ones that I would recommend, definitely QPR, Safe Talk, Assist, and Counsel on Access to Lethal Means. In the month of September, we'll have all of those availabilities for those trainings. I also would encourage you to get involved with your local loss teams, connecting with OSPF about if you have a loss team in your area, because postvention is prevention. And so we know that families who have lost a loved one to suicide are more at risk of dying by suicide. And so we want to provide immediate compassion and support. A lot of work is being done nationally, but specifically in the state of Ohio for lost teams. And so if you're interested in joining a lost team, learning more about it, you can connect with OSPF, or you can connect with your local loss teams. For Montgomery County, I would be the coordinator for that.
We actually have on our website, if you're interested, a map of all the lost teams in Ohio as well, so you can find yours by your county. I also just put a couple of trainings in the chat that folks have been sharing. Pathways to Safety is another one that just came through on restricting access to lethal means. So there are so many great resources out there for prevention. It's just a matter of us taking advantage of everything that's out there and the folks doing the good work. All right. I think that's all we've got for today. I want to thank you all so much for being here. I really appreciate it. Megan, Tania, thank you for such a great conversation. Both the data and then the practical application, I think was really valuable. And you guys did a great job tag teaming. So thank you again. Reminder, you will all receive a follow-up email from me later this afternoon. It'll have a link to the webinar recording posted on YouTube, the slides that these ladies shared, their email addresses if you have specific questions you want to reach out about, and then the survey that you need to complete for your CE credits or your certificate of attendance. Normally, this is when I would plug our webinar for next month, but for September, it's going to look a little bit different because it'll be Suicide Prevention Month. We're going to be doing a more advocacy-focused conversation about some legislation that's actually going to be passed into law in September that OSPF had a part in helping advocate for. So We will have more information out about that via email and on our social media channels. But I hope you all have a great rest of your day. Thank you again for being here and for all of the work that you do. Bye, everyone.
Thank you.